All right. Good evening, everyone. Welcome to NMA Talks, where we feature leading physicians and experts in African American health. This program is specifically designed for a non-medical audience and is brought to you by the National Medical Association, the collective voice of African American physicians and the leading force for parity and justice in medicine. Be sure to like and share this video. I'm your host, Dr. Michael G. Knight. You can find me on Instagram, Facebook, at The District Doc. I'm board certified in internal medicine and obesity medicine, and I'm an assistant professor of medicine at the George Washington University here in Washington, D.C. We have an exciting panel of experts tonight to discuss this very, very timely and important topic, and I want to take some time to do some introductions. We have Dr. Marie Borum. She is board certified in internal medicine, gastroenterology, and geriatric medicine. And she's a professor of medicine and the director of the Division of Gastroenterology and Liver Diseases at the George Washington University in Washington, D.C. Next, we have Dr. Lanla Conteh. She is board certified gastroenterologist and transplant hepatologist and associate professor of medicine at the Ohio State University in Columbus, Ohio. Next, we have Dr. Rachel Issaka, and she's a gastroenterologist and assistant professor at the Fred Hutchinson Cancer Research Center and the University of Washington, where she researches ways to improve colorectal cancer mortality through increased screening in medical underserved populations. And you can find her on social media at Issaka MD. And last but not least, we have Dr. Leon McDougle. He is the 121st president of the National Medical Association, and he is board certified in family medicine and professor of family medicine at The Ohio State University Wexner Medical Center in Columbus, Ohio, where he also serves as Chief Diversity Officer. And you can find him on Twitter at McDougle2020. All right, so why are we here tonight? Colon and rectal cancer is the third leading cause of cancer-related death in men and women in the United States. African Americans have the highest rates of colorectal cancer, which includes colon and rectal cancer, and we'll talk a little bit about the differences of any racial or ethnic group in the United States, according to the American Cancer Society. Colorectal cancer rates are 20% higher among African Americans than for non-Hispanic whites, and the death rates are nearly 40% higher. This weekend, colon and rectal cancer came into the forefront once again when we heard the very unfortunate news of the death of the award-winning actor and really cultural icon Chadwick Boseman at the age of 43. And so we continue to keep his family in our thoughts and prayers and really look at this as an opportunity to continue the discussion around this. So we want to take audience questions tonight, so please look in the chat box and put those there. But let's start off the panel with some questions. So let's start with Dr. Borum. African Americans have the highest incidence and mortality rates of colorectal cancer in the United States. What causes colon cancer, and why are African Americans so heavily affected?
First, I'd like to thank Dr. Knight for inviting me to be here. Thank you, Dr. McDougle, and it's really great to be here with Dr. Issaka and Dr. Conteh. And I am so glad that we're actually talking about this topic because it's not only timely, but it's important. And I want to emphasize the fact of some of the facts that you just brought up. Colon cancer is one of the leading causes of cancer deaths in the United States. African Americans have the highest rate of colon cancer of any ethnic group. We have the highest rate of cancer deaths of any ethnic group. And we have the highest rate of colon cancer in people under the age of 50. So when we talk about what causes colon cancer, we really have to begin to think about risk factors. And one of the risk factors that we talk about is age. As we get older, we have an increased risk for colon cancer. We also talk about heredity. If you have a family member or family history of colon cancer, then you have an increased risk of developing colon cancer, particularly if you have a first-degree relative, a parent, a sibling, or even a child. If you have certain medical conditions, you have an increased risk for colon cancer, like inflammatory bowel disease. And not only do we have to think about those conditions, there are in fact hereditary conditions, although not frequent, but can occur that increase your risk. When we talk about colon cancer, we also want to think about the things that we can do so we have less colon cancer. So we have to think about diet, we have to think about lifestyle, we have to think about activity. And those are some of the things that we have to think about in everybody, but in particular, we have to think about it in our community. Because in our community, we have to make sure that we have access to physicians. We have access to physicians who care enough to make sure that we're screened, and we have to access that care. We have to make sure that we get screened, we get evaluated, and we know that we should get assessed for colon cancer and understand our own risks. What causes it? In most people, sporadic. There are some things that we can do, but the most important thing is that we recognize that colon cancer is common, that we should get tested, and we should get treated if we find it.
Thank you so much, Dr. Borum. Let's continue the conversation. You touched a little bit about screening. Early detection is one of the strongest tools that we have to combat colon cancer. And it's one of the most preventable and easily treatable when early detected. Now, there are many ways to screen for colon cancer. I'm going to bring you in here, Dr. Conteh, including colonoscopies and stool testing and things that we've heard about to screen for colon cancer. At what age should someone start getting screened for colon cancer? And can you comment on the different types of screening options, as well as what might be more appropriate for African Americans?
Absolutely. That's a great question, Dr. Knight. So colon cancer screening is really multifaceted in that there's so many different ways that we can screen for it. We always say that the best screening test is the one that the patient is going to get done. So you mentioned colonoscopy. So we do that incredibly commonly. Patients get sedated for that, but some patients may not wish to go through that. If we do a colonoscopy and it's normal, we recommend doing it every 10 years. In the absence of some of those risk factors that Dr. Borum just discussed, like family history, for example. You also mentioned stool tests. So these are becoming incredibly more common, and we have been doing some of these for several years. So there is something called FIT testing, there's guaiac testing, there's Cologuard testing, and these are really stool samples that patients can do at home and send into their primary care doctor or whichever provider is ordering the screening test. There's also radiologic studies as well that patients can go through. Now, again, I really want to stress that we have a couple of different options. So it's really important for patients and their providers to come together and try to determine which of those options is best for the patient. Any one of those is good as long as it's done well, and most importantly, as long as it does get accomplished. I may order a colonoscopy, but if a patient does not get it done and does not wish to get it done, I have not done them any service, and I would rather order one of the stool tests that they can get done. Now, the second question you asked as far as when should we start screening. So the guidelines are for average risk patients, again, patients without a family history, without inflammatory bowel disease, and some of those hereditary conditions, we should start screening most patients at the age of 50. However, we're here today having this conversation because we know that there is some evidence that shows us that we should start screening African Americans at an earlier age. And some of those studies have suggested that we start screening at the age of 45 for African Americans because of those risks of developing cancer at such an earlier age. Dr. Knight, I think you might be on mute.
Yes, I figured that out. Thank you so much. So like you were saying, it's important for us to think about screening tests, but also what the patient is actually going to get done.
Absolutely.
And that's most important. Without appropriate screening, colon cancer may go undetected for many years. Dr. Issaka, I want to ask you here, are there any signs or changes that someone may feel that would suggest that they may have colon cancer? What would prompt someone's doctor to recommend colon cancer screening before the age of 45?
That's an excellent question, Dr. Knight. And as you highlighted, colon cancer can be largely asymptomatic. So it's really important that screening occur at an appropriate age, as Dr. Conteh mentioned, and that you modify risk factors as we've previously discussed. But the symptoms that should prompt anyone of any age to get evaluated by a physician, and specifically to get a colonoscopy to look for colorectal cancer, those symptoms are blood in your stool, so rectal bleeding. If you notice a change in the caliber of your stool, so what we mean by that is if you normally have, what appears to be normal stool for you, and then all of a sudden you notice they're very pencil thin. If you have unexplained weight loss, losing weight, but you haven't been exercising or dieting to lead to that, abdominal pain, or fatigue, just tiredness that you can't explain. All of those may be signs and symptoms that you may have an underlying cancer. Now, certainly those symptoms are not unique to colorectal cancer. And that's why it's very important to see a medical provider if you're having those symptoms to get the appropriate evaluation, which may include a colonoscopy. Now, as I mentioned, those symptoms in anyone of any age should prompt evaluation. The other people who should get evaluated for colon cancer screening under the age of 45 are those who have a family history. As Dr. Borum mentioned, if you have a first-degree relative, a parent, a sibling, or even a child who has been diagnosed with colorectal cancer, depending on the age of that relative, you may need to begin screening at 40. And if that person who was diagnosed with colorectal cancer was diagnosed at an even earlier age, so for instance, if you had a parent that was diagnosed with colorectal cancer when they were 30 years old, you need to begin screening 10 years before their diagnosis. So that would mean for you that screening would actually begin at age 20 and not age 45, as Dr. Conteh mentioned, for average risk African-American people.
Thank you so much, Dr. Issaka. And I think it's important for us to understand what those signs and symptoms are, because so many of them that you've outlined, abdominal pain, indigestion, or maybe some weight loss, oftentimes goes undiagnosed. And maybe we think, I have so many other priorities, and this is the last thing on our mind. And so that's why I think these kind of conversations with our physicians are so important. I want to bring in Dr. McDougle here. For over 125 years, the National Medical Association has been advocating for health equity and the elimination of health disparities affecting the African American community. And with all the advances in clinical care, here we are in 2020, we continue to see significant disparities in health, and colon cancer is just one of the most recent examples that has come to the headlines. Will we ever achieve equity in health for the African American community?
Good question, Dr. Knight. And that goes to what we termed as the slave health deficit. And with the current consciousness being raised across the United States concerning racism, I know here in Columbus, Ohio, the Franklin County Board of Health and the City Council have declared racism as a public health crisis. So that's just the start. So that means that we have to take down these barriers to fair housing, barriers to fair employment, entrepreneurship, barriers to unequal justice, as we've most pointedly seen in the news. And then I'll borrow a term that I heard from you in regards to healthy food availability. Dr. Knight, you used the term in some of our neighborhoods, it wouldn't be defined as a food desert, but a food mirage. So the corner stores having availability of empty calories that are not nourishing our bodies and protecting us against COVID-19, colon cancer, and other ailments. And also, I want to speak to when you look at the United States and the Affordable Care Act. There are 12 states that have not adopted Medicaid expansion and Affordable Care Act. And guess what? Within the Affordable Care Act, it provides for coverage for colonoscopies. And those 12 states are right in that southeastern swath of the United States where most of us live: Florida, Texas, Georgia, Tennessee, those states, 12 of them. So it's going to involve us continuing to advocate for the elimination of racism and advocacy for our full citizenship in the United States of America.
Thank you so much, Dr. McDougle. And I think you hit the nail right on the head, and brings us to one of our first questions from our audience member that's really outlining. So, are we more prone to colorectal cancer? So we talked about statistics. We do know that African Americans are more likely to be diagnosed with colorectal cancer, as well as poorer outcomes. And the question is why? And I'm going to go to you, Dr. Borum, because I want us to peel back the layers. When we hear about health disparities, a lot of that's hung on socioeconomic differences and coverage for healthcare, which we know is very important. But there have been studies that have shown even when those things are equal, there's still a disparity in the African American community. Can you talk a little bit about that, Dr. Borum?
Certainly. I'd like to speak a little to that. I certainly would like Dr. Issaka and Dr. Conteh to join in, because when we talk about African Americans and development of colon cancer, we really have to look at multiple factors. And the first factor that people very often would hang their hat on, which is what you brought up, Dr. Knight, is it because that there are access issues and are there issues for availability of screening? And certainly that's true for everybody, and it may in fact be particularly true in our community, and that we have to make sure that people understand that it's important to access care when it's available. But indeed, there have been other studies that have also looked at issues related to colon cancer in African Americans. And we, in fact, did a study at our institution where we wanted to peel back that idea that it was because people didn't have access that they got colon cancer. We actually looked at people who had access to care, who had accessed care, and there seemed to be, at that point, some issues related to institutional and physician-provider factors that impacted upon whether someone actually got screened for colon cancer. So not only do we look at people having access, we have to look at people getting the care they need from physicians who are aware that they should absolutely get screened. But then we also move into the issue of, are there lifestyle issues that impact upon colon cancer development that may affect anybody, but could also affect African Americans? Are there issues regarding factors about diet? We know that there are certain factors in the diet that may increase one's risk for colon cancer. For instance, the consumption of red meat and processed meat may be an issue. The issue about having increased fat consumption is an issue. And the issue of maybe not having things like fruits and vegetables that Dr. McDougle brought up about having access to certain types of important nutrients that are protective. So we do have those factors that may impact anybody, but could in fact certainly can impact our community and the whole issue of physical activity. So we have the issue of access, we have the issue of accessing care, we have an issue of diet, we have the issue of activity, and then that brings us to the concept of, is there a genetic predisposition? And that is something that certainly people are evaluating. There are conflicting issues about and conflicting data about whether there is actually a predisposition genetically when everything is controlled for, when everything is equal. Do we actually have an increased risk? And that is not clear that that's the case. But as Dr. McDougle and all of us in the panel know, that things are not equal. And because they're not equal, we have to recognize that our risk factor may be different, and we have to advocate for ourselves and make sure we have providers that advocate for us.
Thank you, Dr. Borum. I'm quickly going to go to Dr. Issaka and Dr. Conteh. I have another question coming up for you, so just wait in the wings. Dr. Issaka, we just heard some of the reasons that may be causing this continued disparity. And when we think about having equal access and institutional or provider differences, can you talk a little bit about what that actually means?
So, when we're talking about equal access, I think we can think about it throughout the continuum of colon cancer disease. If we think about colon cancer in the earlier stages where we're really trying to prevent risk, do Black people have equal access to healthy foods? Do they have access to safe spaces to exercise? And then we can move through that continuum. So, once we then get to screening, do they have access to the right screening test? Do they have access to medical doctors? Let's say they choose a non-invasive test like the stool-based test. Do they have access to a colonoscopy if that is abnormal? Do they have access to health insurance that would allow those things to happen? And then even if they are diagnosed, do they have access to treatment, and so on and so forth? And so I think as we've all been highlighting and talking around, there are certainly structural barriers that have limited access to African Americans in a very systemic way throughout historical context, where that has led to systemic disadvantage that decreases the likelihood that Black people will have access to all of these things that I mentioned, and therefore puts them at higher risk at every step of being diagnosed with, not getting adequate treatment, and then having poorer outcomes if they are found to have colorectal cancer.
Thank you, Dr. Issaka. I'm going to take the next question from the audience. And of course, we are not giving any individual medical advice, but just thinking in a larger scale. If someone, for example, Dr. Conteh, has stool studies that are normal with no symptom, but positive family history, so I'm guessing these are stool studies for screening, but someone who has a positive family history of colon cancer, can a colonoscopy still be avoided? All right,
you're muted. You're muted, Dr. Conteh.
Thank you. So I think we need to spend a little bit of time just trying to understand average risk and high risk screening. So a lot of the screening tests are catered towards patients who are average risk. A lot of our stool testing, for example. When you're a high risk, especially with a family history, you're no longer in that average risk category. You fall into a high risk category. So ideally, what we should be doing is a colonoscopy. Now, keep in mind as well, and the question alluded to this as well, if the stool study is abnormal or any of these other non-invasive tests are abnormal, be that CT colonography, FIT testing, the guaiac studies, if any of those are abnormal, the next step should be a colonoscopy, whether you're average risk or high risk. But if you're high risk, we really need to start that screening earlier, ideally with a colonoscopy.
Thank you so much, Dr. Conteh. Let's go and see, we have another question here. Let's bring this up. All right, what is the role of urgent and re-energized physician advocacy in addressing the disparities in race in, for example, cardiovascular disease, colorectal cancer, COVID-19, that deadly trio? And I'll ask you, Dr. McDougle, thinking not only as the leader, the president of the National Medical Association, but as a family medicine physician, what is the role of physician advocacy?
Very important. It's an urgency of now. If you go to my Twitter page, you'll see the first video that's posted on my Twitter includes the Reverend Dr. Martin Luther King Jr. and speaking to the urgency of now. And in our leadership roles at the National Medical Association, representing the collective voice of over 45,000 African-American physicians and the patients we serve, we have councils, we have health policy committees, council on medical legislation. We right now are collaborating with the Congressional Black Caucus Foundation and putting together webinars. The first is entitled, What the Black Community Needs to Know About COVID-19 and Vaccines. We're also speaking to social determinants of health and criminal justice reform and abolishing the death penalty, the capital punishment penalty. And I know you've all seen the movie with Brian Stevenson and speaking to that issue. We're also convening webinars for addressing clinical trials and care of our older population during COVID-19. So we work with the Congressional Black Caucus Health Brain Trust with Congresswoman Robin Kelly. And so, yes, we are advocating on behalf of our community, and that's a big part of what we do in our leadership roles.
Thank you so much, Dr. McDougle. And we encourage all physicians and everyone in the community, whether or not you're a healthcare professional, there are opportunities to become involved in advocacy and education. So please keep those questions coming. I'm gonna take our next question, which from our viewer. I know some of my family has some form of distrust when it comes to doctors. Is there any way we can inform them? And I'm gonna bounce this to you, Dr. Conteh, because I see you nodding. So let's talk about that. You know, this is real. We are all healthcare professionals, but we cannot ignore the fact that for a variety of very well-founded reasons, there may still be a distrust. And when we think about procedures such as colonoscopies, that may be a barrier. How do you really address that in your practice?
Absolutely. I think this is such an important point to bring up. And this is a big reason why when we look at clinical trials, for example, the number of minorities enrolled tends to be so low because there's still this concept of mistrust and distrust. And to be honest, it comes from a very sincere place. Many of us are well aware of the Tuskegee experiment and what happened back then. An important thing, and you've alluded to this, it's not just the message, but it's the messenger. Who are patients hearing the message from? A study came out recently that showed that Black patients do better with Black physicians. So really the messenger makes a difference as well, and who is the message coming from? And it has to come also from peers, not just from physicians, but I think when we talk about advocacy and educating the community, we need to go out into the community. Go to the churches, go to the YMCAs, and really inform the community so that maybe if someone there hears the message about the importance of screening, they can tell their neighbor about that. They can tell their mother or their father about that. So that distrust and mistrust is well understood. And as a medical society, we have to continue to work hard to overcome that. And really, as educators, which we all are, in medicine, we have to really continue to expand our medical schools to ensure that we increase minority enrollment. So those physicians are there to relate to patients. Now, I want to share just a personal story with you, just relating to this mistrust and distrust. There's so much power in knowledge. I mentioned just before we went live, I'm on service on our inpatient service right now. And last week, I met an 80-year-old woman, an 80-year-old Black woman from 2 miles from the hospital where I was working. She came in with bleeding from her rectum, and she had never had a colonoscopy in her life. She was 80 years old. And I asked her why, and her answer was, it hurts. I know I'm supposed to get one, but it hurts. So no one had told this woman that there were other options available that were non-invasive, to be screened for colon cancer. And secondly, no one had told her that we could sedate her for a colonoscopy to make her comfortable. So we did a colonoscopy on her, and unfortunately, she had a large cancer, and she actually had surgery today. But these are things where we have to make sure as providers that we are giving our patients adequate information to equip them with the knowledge to make the best decisions for them. And as educators, we have to ensure that we bring more people up into what we do to expand the field.
Thank you so much, Dr. Conteh, and for that, personal story. It's something that we see so often, and really takes us to our next question from the audience that delves a little bit more into the hesitancy around colonoscopy. I'm going to bounce this to you, Dr. Borum. We've heard so many things. Those of us who have not had a colonoscopy, you've heard things about the preparation, you've heard things about the process. What are some strategies, or how do you explain a colonoscopy? What is a colonoscopy?
I think one of the things that it's so important is that you make sure that you talk to people and learn what they know about colon cancer, what they know about screening, and be able to meet them at the place where they start, so that together you can walk the journey of figuring out what kind of test you should have and how you should proceed with getting that test. Certainly, I think it's important that we don't come from a place where we think we can tell people what to do, but we make sure we understand that there's a partnership and we are sharing knowledge to allow people to make the best decision for themselves. And I think it's important that we recognize that people don't care how much they know and how much a physician or provider knows until they know how much that physician cares. We don't care about how knowledgeable someone is if we don't believe that they're there to advocate for us, and we don't believe that they're there to be there for us. So when I talk to people about colonoscopies, I talk to them about my own experiences in the healthcare system. I talk to people about how I felt when I was hesitant to go through with what may have been recommended to me. And I talk to them about how I got to the place where I recognized that something was important for me to have. And so when we're considering colonoscopies, when we talk about how important it is to someone as an individual, how important it is to our communities, I think it's important that you give people the information they need in a way they understand, to allow them to make the decision with you, to decide what's best for them. We can't tell people what to do. We are part of a partnership to allow people to be able to have the screening that they need so they can take care of themselves, so they can be their own advocate in healthcare. So I encourage my hesitant patients by telling them what their options are and telling them that maybe if they're particularly hesitant, they don't need to make that decision today, but they certainly can come back tomorrow. And I will certainly check in with them next month so we can continue the conversation until we get them to a place where they understand how to optimize their own health and how to make sure they get the screening that they need.
Thank you so much, Dr. Borum. Before we have another question that came in separately. I'm going to have this off the screen here. And I'm going to turn this to Dr. Issaka. You do a lot of work thinking about the disparities around colon cancer. And unfortunately for some people, the screening is positive. So Nicole, you've had a colonoscopy, maybe there's a polyp, maybe there is, God forbid, a cancer. What's the prognosis? How is colon cancer treated?
So colon cancer, when found at an early stage, the prognosis is very good. When we mean early stage, we mean it's just confined to that area where the polyp was found or the surrounding tissue, and it hasn't broken off and gone through the wall of the colon, or it hasn't spread to other parts of the body. So when you're in that early stage, the 5-year mortality, so meaning, how many people are living 5 years after that diagnosis, it's over 90%. So those are really quite good numbers. And again, why we advocate for, if you're having any sort of symptoms the symptoms I discussed earlier, or if you're of screening age, to get screened, because that's the best way we can find earlier stage disease. Now, for those who are ultimately diagnosed, oftentimes we work in partnership with oncologists, so cancer doctors, and there are several options available to patients. If the cancer is, just confined to that area of the colon, oftentimes it can be a surgery to just remove that part of the colon. And the colon is quite long. And so if a small section has to be removed, often that's quite all right. And for some who need a little bit more than just having that part removed, your oncologist, your cancer doctor may also talk to you about chemotherapy or even radiation sometimes if the cancer is really low down in the rectum. But all of these treatment options really work very well for those who have earlier stage disease. And for advanced stage disease, the responses aren't as good as earlier stage, but we still have a lot of options, a lot of clinical trials that are testing new medications. And so everyone should really feel confident in working with their gastroenterologist and the oncologist that they work with to come up with the right treatment plan for them.
Thank you so much. We have another question here, really talking about the causes. We're going to jump back to that, and I'm going to bounce this to Dr. Conteh. So what was posted in the chat was there've been some research on known non-hereditary genetic links and mutations with a variety of genes and different syndromes. So could we conclude that colorectal cancer incidence, prevalence, and mortality is solely linked to our behaviors and not our shared genetics linked to ancestry, or is it some kind of combination?
I think what we suspect is that there may be a combination. As Dr. Borum alluded to earlier, there's data that potentially our ancestry does play a role in this, but it's not entirely clear. So we know that the incidence, the prevalence, and mortality, yes, significant amount of that is linked to our behavior, especially when we talk about all the access issues that we've discussed. Our behavior, our lifestyle, socioeconomic status, all of those play a significant role. And we know genetic factors play a role as well, because we know they're hereditary, gene-proven DNA mutations that cause colon cancer. But when we talk about ancestry specifically related to being Black, that I will say is not entirely clear. But our behavior and where we live in our lifestyle plays a huge factor. And the access, again, as has been mentioned, cannot be understated. That is a significant, significant factor.
All right, thanks, Dr. Cross, for that question. Let's take another question. I'm going to bring in Dr. McDougle, because Dr. McDougle and I both share the fact that we are primary care physicians as well as a variety of other hats, right? And so as a patient, so you have gone into the doctor's office and said, I've seen an article, I have watched this Facebook Live, I'm 48, and I want to get screened for colon cancer. And they are told, recommendations are 50. Or maybe I don't think that you necessarily need a colonoscopy. How can a patient have a conversation with their primary care provider, which we know is often the person that's either a gatekeeper, you can say, or usually the first person that's leading someone to screening?
Yes, so another very good question, Dr. Knight. So that goes back to what was spoken to earlier about getting a history, a better history. You may find that there is a family history of higher rates of colon cancer in that person's family. That person may have had some symptoms that can be brought out during the discussion. And so also it may involve a referral to the gastroenterologist for a discussion to try to evaluate the risk and availability of colonoscopy screening. I know in Columbus, we have some free Saturdays where one of our colleagues and the group that Dr. Conteh is in provide free colon cancer screening. So I think it would involve more of a history, bringing in the GI group, especially those groups that are committed to serving the community, like we have at our institution at The Ohio State. So I think that would be a part of how I would approach this, Dr. Knight.
Thank you. Let's bring everyone back. All right. So we have another question here, specifically around frequency. So should colorectal cancer screening be done every 5 years in African American patients? And I think that speaks to a larger question of what goes into the frequency. You know, some people come back from their colonoscopy and it's, I'll see you in 10 years. And some people have to come back in 6 months. Dr. Borum, tell us what's behind that. Why is there a difference in frequency?
The difference in frequency of when someone does their colon cancer screening is dependent upon their personal risk factors and also dependent upon what may have been found in their previous procedures. So when we have someone who's at average risk for colon cancer and they get their colonoscopy at the designated time, and they have a normal colonoscopy, they would then be recommended to come back in 10 years. Someone comes back in 5 years if they've had a previous history of having a polyp, and a specific type of polyp, an adenoma, that makes it so that someone will come back more frequently than the 10-year mark. Or if someone has a risk factor like a family history, if there's someone who has a family history of colon cancer in a first-degree relative, or multiple other relatives that suggest that there's an increased family risk, that would increase the frequency at which time you come back. If there are certain clinical conditions that you have, like inflammatory bowel disease, that changes when you come back, and that you may come back every 1 to 2 years based upon the inflammatory bowel disease history or other genetic factors. In general, if you have an average risk African American person who is having colon cancer screening, it's important that they start their screening on time, but we don't have to decrease the years in between screening if their colonoscopies are normal.
Thank you so much, Dr. Borum. And I think you really hit on that point of depending on what their risk factors are, maybe what they find on the colonoscopy, that is going to be the biggest factor in saying when the next one. But we know that the first one for African Americans should be at age 45. It seems like there may be a little bit of controversy around that. I know that there are some recommendations that it's 50 for everyone. We know the American Cancer Society does recommend age 45. And this is open to anyone in the group. Can you talk a little bit about that? I mean, that could obviously be confusing for a non-medical person. So whoever wants to take that one.
Sure, I can begin to answer that question. So what we know is colon cancer is still most prevalent in those who are older. So the majority of cases are still diagnosed in individuals who are over the age of 50. And that's where the most recommendations from the U.S. Society for Preventative Services Task Force, USPSTF, that's where those recommendations come from. But we also know that in the past decade or so, so between 2008 to 2013, we've started to see an increase in colorectal cancers in those who are under 50. So between those years, for every year, we've seen a 2% increase in those who are under the age of 50. And now, while those numbers are low, that trend is still concerning. And that is what's leading organizations like the American Cancer Society to recommend that everybody begin screening at age 45. As we've all been talking about, African Americans have the highest risk for being diagnosed with colorectal cancer. They present at later stages, and they're more likely to die from colorectal cancer for all the reasons we discussed. So for that reason, that's why screening is recommended in that population starting at age 45. And that's been that case. That has not changed. It's really the other guidelines around everybody else who may be younger than 50, where there's a lot of debate. And hopefully all of the different guideline organizations will arrive at consensus soon for patients. If you are a patient and you are uncertain of your family history, please talk to your providing doctor. And together with them, you can come up with the right answer for you on when you should begin screening.
Thank you, Dr. Issaka. And so again, that just highlights you have to have that conversation with your healthcare provider. If you don't have a doctor or provider that you can communicate with and really express your fears, your history, then that's a challenge. And we at the National Medical Association, as well as a variety of organizations, are happy to help to connect you with physicians in your area. I have another question for the panel. When we think about colonoscopies, when we think about different stool testing, is there anything on the horizon? You know, we've heard about some people do a CAT scan tests where they're doing imaging and it's completely non-invasive. Sometimes they call it virtual colonoscopy and a variety of other things that may be coming down the line. Dr. Conteh, do you want to comment on anything? Is there anything we should be aware of that may be on its way?
I think one of the important things, because you alluded to CT, colonography or virtual colonoscopy, people call it. Mm-hmm. So what happens with the virtual colonoscopy, essentially, you're getting a CAT scan, which is an imaging study, and it's taking a very close look at your colon. Now, if that's a screening test that's done, we usually recommend doing that every 5 years. Again, the important thing that I want to stress is that any of these other screening tests outside of a colonoscopy, things that are in the pipeline, things that are currently what we're doing, if any of those are abnormal, the next step is a colonoscopy. An important thing to think and to remember about the CT colonography, the virtual colonoscopy, is the bowel prep that's involved. And I know that we have not talked about that so much, but I just want to spend a little bit of time talking about that, because I think that really can be a turning away point for a lot of patients. So in order to undergo a colonoscopy, you have to clean your bowels, meaning that we have to evacuate stool so we can get a good look at the walls in your colon to look for polyps or to look for cancer or other types of inflammation. Now, with the stool test, we don't have to do that. But with a colonoscopy, virtual colonoscopy, or sigmoidoscopy, we do have to do a bowel prep. And Dr. Knight, I just want to highlight, the reason I bring that up is really to talk a little bit more about this, because I think that can turn patients away. When we talk about access, if you live on a bus line and you have to take a bus to go to the hospital, and you have drank colon prep to clean out your colon, and you have to get on a bus, you can imagine why a patient would not want to get a colonoscopy done, to be on a bus after something like that. Or for patients who are undergoing sedation and need a driver, that's another access issue if you don't have someone who can drive you and wait with you until you complete the procedure to drive you back home. So we have, again, all these other screening modalities, fantastic things that we do that can be utilized instead of a colonoscopy. Again, the most important screening test is the one that's going to get done. As far as what's coming down the pipeline, a lot of those tests are focused on DNA testing. I mentioned Cologuard earlier, and that's one of the stool sample tests that looks specifically for DNA mutations within the stool. And there are some other tests along those lines coming through.
Thank you so much. And you hit it. As a primary care physician and having conversations with people around colonoscopies, it's often the prep. We have patients who come to the colonoscopy and the prep's not done correctly, and they have to go home and come back. And if time is taken off of work, childcare, as well as transportation, right? So we know that if someone is sedated, they can't drive home. And so really having an ability to have someone to help you can be a challenge. Here's another question that often comes up. We talked a little bit about food, but let's get a little bit more specific. Are there specific foods that can increase your risk for colon cancer? Dr. Borum, you want to take that one?
Sure. There have been a number of studies that have tried to determine whether certain nutrients that we take in or certain diets that we have, whether that impacts our colon cancer risk. And in fact, there is good evidence to suggest that there are some foods or some diets that increase one's risk for the development of colon cancer. One of the things that we know, if we're looking at things that can increase our risk, things that make the possibility of you developing colon cancer higher, or people who are increased risk make you have it develop earlier or faster, include things like a diet that is high in red meat and processed meat. We know that there is good evidence to suggest that red and processed meat consumption can increase one's risk for colon cancer. We also know that a diet that's high in fat may increase one's risk for colon cancer. And so we know that those factors are dietary factors that can increase our risk. Increased alcohol can increase our risk for colon cancer. On the other hand, there's evidence to suggest that there's some dietary factors that may decrease our risk for colon cancer. So a diet that's high in fruits and vegetables may decrease our risk for colon cancer. So in fact, we therefore suggest that you have an increased amount of fiber, fruits, and vegetables in your diet. We do have some evidence that suggests that adequate calcium, vitamin D, and perhaps vitamin B6, and even perhaps some fish may actually, or omega supplements or fish can increase our protective factors against development of colon cancer. The area in which there has been the most work has been the area of dietary or animal fat, meats, processed meats, alcohol. Those are the dietary factors that can make a difference. But you say that it's not everybody who has those things can actually have more colon cancer. Well, I think of it as the circumstance. If you are at increased risk, having another additive factor can make your risk that much worse. But the factors that have been the most studied are the ones that we just talked about.
Thank you. We're coming to our final minutes. If anyone has any last minute questions, this is an opportunity to put that in the chat. I'm going to go to Dr. Issaka. We hear so much about organizations. So the American Cancer Society, the Colorectal Cancer Alliance, for example, who have done education in the larger community, but also in the African-American community. Can you talk a little bit about what some of these organizations and some of the initiatives that may be available to patients, but also people who may be at an increased risk and want to learn more information?
So there are several organizations. The ones that I will speak to are the ones I'm most familiar with. So within gastroenterology, there are 4 major societies: the American Gastroenterology Association, American College of Gastroenterology. There is the American Association of Gastrointestinal Endoscopists, and there's also the American Association for the Society of Liver Disease. And so all of those organizations really do work around increasing awareness around colorectal cancer screening. And then you have advocacy groups, and those include organizations like Fight CRC, the Colorectal Cancer Alliance, and several others that do work in this space as well. And I know that those organizations are really engaged in community engagement and advocacy work on Capitol Hill as well as locally within communities, and have programming specifically targeted towards communities of color and Black people. So if you're looking for information around colorectal cancer screening and your risk and understanding risk factors, feel free to just Google search any of those organizations that I named, or you can just simply type in colon cancer advocacy groups and a list will come up, and you can direct yourself to those websites to get informed on what is happening nationally as well as what resources are available to you locally.
Thank you so much, Dr. Issaka. We're coming to the conclusion of our program. I want to give one more opportunity for Dr. McDougle, who again is the president of the National Medical Association, and under his leadership, we have been able to continue these initiatives of bringing the best in African American health. and the leaders in those areas directly to the general public. Dr. McDougle, if you want to just give a couple of words on some of the work that the National Medical Association wants to continue to do to spread information on issues such as colorectal cancer directly to our community.
Yes, so Dr. Michael Knight, I just want to commend you for convening NMA Talks. This platform itself is one of those vehicles to help educate the community. We also collaborate with a number of other organizations. Over this past week, I participated in virtual town halls with the Rainbow Push Coalition led by Reverend Jesse L. Jackson Sr., have talked with Dr. Robert Redfield from the CDC, Dr. Francis Collins from the NIH, director of both of those institutes. We are speaking to media, and I've really put a focus in my term as president of communicating with the National Association of Black Journalists, members of that organization, because we want to speak to Black people, African Americans, especially, not excluding other communities. That's our focus as an organization. So we're speaking to the nation, to Black people through various venues and through our councils, committees, president-elects, chair boards, and the like. So, and so much want to commend Dr. Lanla Conteh, Dr. Rachel Issaka, and Dr. Marie Borum for all the expert advice given tonight in support of this wonderful initiative that you have started with the National Medical Association. Dr. Knight.
Thank you, Dr. McDougle, and thank you again to our panel. But let's do some, quick take-home points. So as we wrap, the fact is colorectal cancer is real and it is affecting the African American community, and we can't depend on someone else. We have to know and have the knowledge ourselves that this is important. At age 45, you should be starting colorectal cancer screening as an African American. And if it runs in your family, it may even be earlier than that. So have a conversation with your healthcare provider about your family history as well as your personal history of colorectal cancer. And also, don't ignore the signs of your body, whether it's weight loss, whether it's upset stomach, changes in your bowel habits. Have a conversation and really want to be an advocate and being empowered for your health. So again, thank you all for joining us for NMA Talks, brought to you by the National Medical Association. A special thank you to our guests, Dr. Leon McDougle, Dr. Marie Borum, Dr. Lanla Conteh, and Dr. Rachel Issaka, and our producer, Dr. Chanda, Holsey, who's in the background. Please follow and connect with us at National Med ASSN, where you can find recordings of this and previous NMA Talk programs. And please share this with your networks. This recording will be available. So if people have questions about colorectal cancer in the African American community, share this video and send it to someone that you love. Feel free to email us at nmatalks@gmail.com with any questions and comments, and be sure to join us for future programming. Until then, I'm Dr. Michael Knight, wishing you all a good night. Thank you for joining us.
Good night.